welcome to the deep dive. Today we're plunging into something absolutely vital, perfusion. Think of it as your body's internal delivery system, the incredible process of blood flowing through your vessels, carrying oxygen and nutrients everywhere they need to go. And this specific deep dive is actually sparked by you, one of our listeners who shared a stack of sources, really curious about this crucial aspect of health. So, our mission, to sift through that material, pull out the truly need-to-know insights, and explore what they tell us about keeping this system running smoothly.
It's such a fundamental area, really, because when blood flow is off, well, the effects can show up almost anywhere in the body. Understanding perfusion helps, connect the dots between things like blood clots, high pressure, and circulation problems you might notice in your limbs. It's about navigating these key conditions that disrupt that essential flow.
Exactly. So, guided by this source material we've got, we're going to explore three big areas today. First, the potential problem of blood clots forming in your veins. That's venous thromboembolism, covering DVT and PE. Then we'll shift to the pressure inside your arteries, the often silent challenge of hypertension. And finally, we'll look at how flow issues can specifically impact your legs and feet, discussing peripheral vascular disease, particularly PA and CVI. Okay, let's unpack these sources and see what insights jump out. Let's kick things off by diving into blood clots, specifically venous thromboembolism, or VTE. The source material tells us this umbrella term includes deep vein thrombosis, DVT, which is a clot usually in a deep vein of the leg.
Right, usually the leg.
And pulmonary embolism, PE, which is when that clot, breaks off and travels all the way to your lungs.
Yeah, and what's fascinating here is the source gives us a foundational concept for understanding why these clots form in the first place. It's called Virchow's triad. It highlights three main contributing factors that often, work together. The first is simply alterations in blood flow.
Alterations in flow, like blood just sitting there.
Exactly. If blood isn't flowing well, it can pool or become stagnant. They call this stasis. Think about situations like being immobile for a long time, maybe after surgery, or even just sitting for hours on a plane or car ride. Conditions like heart failure, where the heart isn't pumping as efficiently, can also contribute to this pooling. The source really zeroes in on immobility as a major culprit here.
Okay, so blood pooling is one. What's the second factor?
The second factor in the triad is vascular damage. If the wall of a vein gets injured, maybe from trauma, like a fracture or surgery, or even just irritation from medical devices like catheters or IV lines, it triggers a response that makes clotting more likely right at that site.
Ah, makes sense. Damage attracts clots.
Pretty much. And the third piece is hypercoagulability.
Hypercoagulability, so thicker blood.
Sort of. It's when your blood is just more prone to clotting than it should be. The sources mention several things that can cause this. Stopping anticoagulant medications abruptly is one. Others include conditions like certain genetic disorders, using oral contraceptives, and notably, pregnancy. The source stresses pregnancy significantly increases clotting risk. And something very current highlighted in the source is that COVID-19 infections can induce inflammatory changes that also ramp up hypercoagulability.
Wow, COVID too.
Yeah. So you can see how these factors flow, changes, damage, and blood being stickier can combine to create the perfect storm for a clot.
That makes sense. It's not just one thing, but often a mix.
Yeah.
So pulling from the source, who does this perfect storm effect most often? The risk factors listed are pretty broad. Age is a factor, particularly over 40 and even more so over 60. Women in childbearing years have a higher risk than men, especially if they're pregnant or using oral contraceptives.
Right.
Recent surgery, particularly major abdominal, orthopedic, or OB procedures, significantly increases risk, as does simply being hospitalized for other reasons. Conditions like heart failure and obesity are on the list. Smoking is there too, which makes sense given its impact on blood vessels.
Always smoking.
Yeah. Having central venous catheters is another risk. And as we just mentioned, COVID-19 infections are explicitly listed as increasing risk. It's quite a range.
It really is. Now, detecting these clots can be challenging because, and the source strongly emphasizes this, they are often asymptomatic initially. You might not know one is forming.
Right, that's scary.
It is. But when a healthcare provider suspects a clot, they use diagnostic tests. The D-dimer blood test is mentioned. If it's low, it's great at ruling out a clot. But if it's high, it just means something is causing clotting activity somewhere, so more investigation is needed. It's sensitive, but not super specific,
Okay, so a high D-dimer doesn't automatically mean DVT or PE.
Exactly. Duplex venous ultrasound is highlighted as a key test because it can actually visualize the clot in the vein. It shows you if it's there. The source also mentions checking certain blood tests related to clotting, like platelet count, PTT, PT-TAP-PT, and INR. The insight here for our deep dive isn't memorizing the numbers, but understanding what these monitor. PT and INR are typically used to check the effect of warfarin, while PT-TAP-PT is used for heparin therapy. Knowing that these tests exist and link to specific medications is the key takeaway here.
Got it. So specific tests for specific drugs. Okay, so if someone does have symptoms, what might they feel according to the source?
The description is usually a dull, aching pain in the affected limb, often feeling worse when you're walking or moving. You might find the area is tender to the touch, feels warm, looks red, or is swollen. Yes, and the source points out this swelling is often unilateral, meaning it's just in one leg, which is a strong clue for DVT. While they mention a palpable cord along the vein, it's noted as rare. And it's crucial to remember, as the source stresses, that symptoms like sudden shortness of breath or chest pain could indicate a pulmonary embolism, which is absolutely a medical emergency needing immediate attention.
Right, PE is the really dangerous complication. So prevention is obviously key. What does the source say about that?
Prevention is definitely better, and the source outlines both non-pharmacologic and pharmacologic ways to do this. Non-drug methods include simple things like encouraging early movement after surgery, doing leg exercises, elevating the foot of the bed to promote venous return.
Basic stuff, but important.
Very important. And using mechanical devices like intermittent pneumatic compression devices, IPCDs, those leg squeezers for people who are immobile. There's an interesting distinction made about compression stockings. TED hose are typically for non-ambulatory patients, while graduated compression stockings with higher pressure at the ankle are for mobile people to aid venous return.
Ah, okay, different types for different situations. And what about meds for prevention?
Pharmacologic approaches primarily involve anticoagulant medications, the blood thinners, things like low molecular weight heparin, LMWH, or maybe oral anticoagulants, depending on the situation.
And for treatment if someone has a clot.
Well, the main treatment is also anticoagulants like heparin, warfarin, or enoxaparin, which is Lovenox. But the source makes a really important point here. These medications do not dissolve the clot that's already there.
Oh, really? I thought they were clot busters.
Nope. Their job is to stop the existing clot from getting bigger and prevent new clots from forming while the body works on breaking down the old one over time. That's a key distinction.
Okay, that is important. They prevent worsening, not dissolve.
Exactly. And if someone on these meds develops excessive bleeding, the source mentions specific reversal agents. Protamine sulfate for heparin and vitamin K for warfarin. Surgical options like actually removing a clot, venous thrombectomy, or placing a filter in the large vein in the abdomen, an IVC filter, to catch clots before they reach the lungs are also mentioned, but they're usually for specific situations, not routine.
Gotcha. And you mentioned a nursing note earlier.
Yes. A critical nursing consideration highlighted in the source is about the Homan sign, that old method of checking for calf pain when you flex the foot. The source firmly states it's unreliable and not recommended anymore.
Why not?
Partly because it's just not accurate, and partly because there was always a theoretical concern it could potentially dislodge a clot if one is present, so best avoided. Also, constantly assessing patients on anticoagulants for any signs of bleeding, like unusual bruising, blood in urine, or stool, is absolutely paramount. Education is key there.
All right, that's a really good overview of VTE. Let's pivot now from blood clots moving through veins to the pressure inside your arteries. The source calls hypertension, high blood pressure, the silent killer. Why? Because, as it notes, you often have no symptoms at all, at least not initially.
That's exactly it. It can be doing damage without you even knowing. The source defines hypertension based on blood pressure readings, typically 2 or more readings taken on separate occasions that are higher than a 129/80. It gives us the current classification ranges. Normal is less than 120/80. Elevated, sometimes called prehypertension, is 120/129 systolic and less than 80 diastolic. Stage 1 is 130/139 systolic or 80/89 diastolic, and stage 2 is 140 systolic or 90 diastolic or higher.
Okay, those are the numbers. And BP itself is just the force?
Simply the force that blood exerts against the walls of your arteries as it flows, and it's determined by things like the resistance in your blood vessels and how much blood your heart is pumping out, cardiac output.
The sources talk about two main types, right? Primary and secondary.
Correct. Primary or essential hypertension makes up the vast majority, like 90–95% of cases. And for these, there's no single identifiable cause. It's complex, involving various systems in the body. The source mentions things like the renin-angiotensin-aldosterone system, RAAS, and adrenergic receptors.
So most people just develop it.
Essentially, yes, due to a combination of genetic and environmental factors over time. Secondary hypertension, the remaining 5–10%, does have an identifiable cause. The source lists examples like kidney disease, certain medications like some decongestants or NSAIDs, sleep apnea, and even pregnancy-induced hypertension.
Interesting. And looking at who's affected, the incidence is quite high.
Very high. The source says about 46% of U.S. adults over 20 have it. It's most common in middle-aged and older adults. And a very significant point the source emphasizes is the higher incidence and severity of hypertension in African Americans. They often develop it earlier and have worse outcomes.
That's really important to note. So what puts you at risk for developing high blood pressure, according to this material? Can we break down the modifiable versus non-modifiable factors?
Sure. The modifiable list, the things you can potentially change, includes diet, especially how much sodium you consume. High sodium is a big one. Obesity is key. Losing weight really helps. The source even notes that losing just 1 kilogram, about 2.2 pounds, can drop your systolic BP by about 1 milliliter each G on average. That adds up.
Oh, that's quite direct.
It is. Drinking too much alcohol, not being physically active, and stress are also on the modifiable list. And smoking and nicotine use are highlighted as particularly crucial because they cause blood vessels to constrict, raising pressure.
What about things you can't change?
Those are the non-modifiable risks. Things like your age, risk increases as you get older, race, as we mentioned, higher in African Americans, genetics and family history. If your parents had high BP, your risk is higher. And whether you've had hypertension during a previous pregnancy. The source also mentions possible connections to insulin resistance, like in diabetes or prediabetes, and even vitamin D deficiency being potentially linked.
And why is it so important to control this silent killer? The complications sound serious.
They really are, and they affect multiple organ systems. The source lists heart failure. The heart muscle gets tired from constantly pumping against high pressure. Also, heart attacks, myocardial infarction, or MI. Chronic kidney disease, CKD, because the kidneys are damaged by high pressure. Vision loss due to damage to the blood vessels in the eyes. Retinopathy potentially leading to blindness. Stroke.
So brain, heart, kidneys, eyes.
Exactly. And hypertensive crisis.
Okay, the source went into detail there. What's the difference between a hypertensive emergency and urgency?
This is a critical distinction. It all comes down to the presence of new or worsening target organ damage. In a hypertensive emergency, your blood pressure is severely elevated, typically over 108/20. And there's evidence of acute damage happening right now to organs like the brain, stroke, encephalopathy, heart, MI, heart failure, or kidneys, acute failure. This requires immediate lowering of BP, often within an hour, usually using IV medications in an ICU setting to prevent permanent damage or death.
Okay, emergency means active organ damage, needs immediate IV meds.
What about urgency? A hypertensive urgency is also very high blood pressure, maybe in the same range, but crucially, there's no immediate evidence of progressive organ damage. It still needs attention and medication adjustment, usually with oral meds, but it's not the same level of immediate life-threatening danger as an emergency.
That makes sense. Damage is the key difference.
Precisely. And there's a little nursing note in the source about patients receiving IV vasodilators during a crisis. Monitoring their fluid intake and output is important. Giving too much fluid with potent vasodilators could potentially cause sudden drastic drops in BP.
Good point. How is hypertension diagnosed, beyond just getting a few high readings in the office?
Well, confirming with multiple readings, often in both arms, is step one. But the source lists several other tests a doctor might order to check for underlying secondary causes or to assess for any existing organ damage. These include an ECG to check the heart's electrical activity and look for strain, a urinalysis and blood tests like creatinine and electrolytes, potassium, calcium, vitamin D to check kidney function and other factors.
Looking for those secondary causes or damage.
Exactly. Also, blood glucose to screen for diabetes, which is a major risk factor, hematocrit, part of blood count, and a cholesterol profile to assess overall cardiovascular risk.
Oh, okay. So once it's diagnosed, taking control often begins with lifestyle changes. What does the source recommend?
The source strongly backs lifestyle modifications. The DSH diet is highlighted. That's dietary approaches to stop hypertension. It's rich in fruits, vegetables, whole grains, lean protein, low-fat dairy, and importantly, low in sodium, total fat, saturated fat, and cholesterol.
So a generally healthy eating plan.
Pretty much, with a specific focus on lowering sodium and boosting potassium and calcium. We already mentioned weight loss and the impact of losing even a little. Regular physical activity is crucial. The source might specify types like aerobic exercise for a certain duration most days. Limiting alcohol intake and stopping tobacco use entirely are critical. And finding ways to reduce and manage stress is also key.
And if lifestyle changes aren't enough?
Then medication comes into play. The source lists several first-line classes of drugs. Diuretics, especially thiazides, are often the first choice, and the source notes they're particularly effective in African Americans.
Okay, diuretics first. What else?
ACE inhibitors, which often end in pulpirol, work on that RAAS hormonal system. A common side effect is a persistent dry cough and rarely a serious swelling called angioedema. ARBs, often ending in sortan, work on the same system but differently and tend to have fewer side effects like cough. Calcium channel blockers, which might end in ecipine, amyl, or AASM, relax blood vessels. They can sometimes cause pedal edema, swelling in the feet, and headaches. And beta blockers, ending in olol, slow the heart rate and reduce the force of contractions. They require caution in patients with certain lung conditions like COPD or asthma because they can sometimes affect the airways.
That's a lot of options.
It is, and often people need more than one. The source also briefly mentions resistant hypertension, which is when blood pressure remains uncontrolled even on a regimen of 3 or more different medications, including a diuretic. That requires more specialized investigation.
And there's a note about older adults.
Yes, a specific gerontologic consideration. Challenges for older adults can include remembering complex medication schedules and the cost of drugs. Using a single medication if possible, monotherapy, might help with adherence. Involving family or caregivers can be really important. And due to medication side effects like dizziness, monitoring for falls, especially related to orthostatic hypotension, that's BP dropping significantly when you stand up, is crucial.
Good practical advice.
And one more nursing note from the source. This is typically lifelong therapy. It's not something you just take for a while. And patients should be advised to avoid over-the-counter sinus or cold medications containing decongestants, as these can cause vasoconstriction and raise BP, working against their treatment.
Oh, good warning about OTC meds. Okay, let's move our deep dive down to the extremities now, focusing on circulation issues often seen in the legs and feet. The source refers to this broadly as peripheral vascular disease, or PVD, clarifying that this includes both arterial and venous conditions. It also defines atherosclerosis, that buildup of plaque in arteries, which is often the root cause of the arterial problems.
Exactly. Let's start with the arterial side. Peripheral arterial disease, or PAD. The source describes the underlying problem as narrowing and thickening of the arteries in the limbs, usually due to that plaque buildup, often where arteries branch off. This plaque obstructs blood flow downstream of the blockage. So tissues below it don't get enough oxygen and nutrients. This can lead to ischemia or tissue damage, and in severe cases, necrosis, which is tissue death. It's most commonly seen in the arteries of the legs.
And who gets PAD?
The source notes that PAD is more common in older adults, usually over 60, affects men slightly more often, and significantly is much more prevalent in patients with diabetes. Diabetes really accelerates atherosclerosis.
Okay. What are the signs? The source highlighted pain as key here.
Yes, pain is the hallmark symptom for PAD, according to the source. Specifically, intermittent claudication. This is that characteristic aching, cramping, or fatigue feeling in the leg muscles, often the calf that comes on with activity like walking and gets better with rest.
So pain when moving stops when you stop.
Precisely. It tells you the muscles aren't getting enough blood flow when their demand increases during exercise. A more severe sign is rest pain. This is intense pain even when you're not moving, usually felt in the feet or toes, often worse at night when lying flat. It indicates severe, constant ischemia and is a sign of critical limb ischemia.
That sounds awful. What other signs might you see?
Other signs, according to the source, include decreased or even absent pulses in the feet. The skin might look thin, shiny, and hairless because the follicles aren't getting enough blood. You might see color changes. The foot might look pale when elevated, elevational pallor, and then turn reddish purple, dependent rubor, when hanging down. Toenails can become thick and brittle.
And ulcers. The source mentions specific types of ulcers.
Right. Arterial ulcers can form, and the source describes these as typically very painful, small, deep, with a punched-out appearance, often located on the pressure points of the feet, like the toes, heels, or outer ankle. In the worst cases, gangrene or tissue death can develop.
How is PA diagnosed?
Diagnosis might involve simple things like checking pulses and comparing blood pressure in the ankles and arms, ankle brachial index. Tests like a duplex Doppler ultrasound can assess blood flow, Or an arteriogram, which uses dye and x-rays, can visualize the arteries directly to pinpoint blockages. The source also mentions checking inflammatory markers like CRP and lipid levels.
What about medications?
Medications listed include antiplatelets like aspirin or clopidogrel to prevent blood clots from forming on the plaque. Drugs like cilostazol are mentioned specifically to help improve walking distance by reducing claudication symptoms. And statins are crucial to manage cholesterol and slow down the progression of atherosclerosis itself.
Okay. Now, you mentioned positioning earlier. What's the key takeaway from the source for PAD positioning?
Yes, this is a crucial nursing consideration from the source and maybe counterintuitive for some. To help blood flow get down to the feet via gravity, legs should be kept in a neutral position or even slightly dependent, meaning level with or below the heart, like hanging down when sitting.
So don't elevate the legs with PAD.
Generally, no. Elevation works against arterial flow getting down there. Also, exercise, specifically walking to the point of pain, resting briefly, and then continuing, is actually encouraged. This helps the body build up new collateral circulation pathways, like natural bypasses around the blockages.
Interesting. Walk into the pain a bit.
To the point of pain, then rest, then resume. That's the idea. The source also warns strongly against applying direct heat to the affected limbs, like heating pads.
Why no heat? Seems like it would help circulation.
Because the tissues already aren't getting enough oxygen. Heat increases the metabolic demand of those tissues, making the oxygen deficit even worse. Plus, sensation might be reduced due to nerve damage from poor circulation, increasing the risk of burns. So avoid heat.
Okay, that's clear. Avoid elevation, encourage walking, avoid heat for PBA. Now let's look at the other side of PVD, chronic venous insufficiency, or CVI.
Right. So here, the problem isn't blocked arteries delivering blood down, but issues with the veins returning blood up to the heart. Often it involves the valves inside the veins that are supposed to prevent blood from flowing backward. If these valves are damaged, maybe from a past DVT or just incompetent, or if there's an obstruction, blood can pool in the legs. This leads to increased pressure in the veins called venous hypertension.
And how is CVI diagnosed?
Diagnosis often involves a duplex ultrasound, similar to DVT diagnosis, but this time they're specifically looking at the function of the venous valves to see if they're allowing reflux or backward flow, and also checking for any obstructions.
What does CVI look like? How are the symptoms different from PB?
The clinical manifestations are quite different. Instead of pain, with activity being the main thing, with CVI, you'll typically see swelling or edema in the lower legs and ankles, often worse as the day goes on and improving overnight with elevation. You might notice pigmentation changes in the skin, specifically a brownish discoloration around the ankles, especially the inner ankle. This is called hemosiderin staining, and it comes from iron pigment leaking out of red blood cells from the pooled blood under pressure.
Ah, that brown staining. I've seen that.
Yeah, it's characteristic. And the classic sign here is the venous stasis ulcer. The source describes these as typically less painful than arterial ulcers, maybe more of an ache or heaviness. They tend to be larger, more superficial with irregular borders, and they are commonly found around the ankle area, often on the inner side, the medial malleolus.
So different location, different look, different pain level compared to arterial ulcers.
Exactly. And the symptoms of CVI, like the aching, heaviness, and swelling, are usually worse in the evening after you've been standing or sitting all day, which makes sense because gravity has been working against venous return.
Okay, so how is CVI managed?
Yeah,
It sounds like the opposite approach to PAD might be needed.
you got it. Management for CVI is all about reducing that blood pooling, stasis, and preventing complications like ulcers. So the positioning is actually the opposite of what we do for PAD. The source recommends elevating the legs above the heart frequently throughout the day, maybe 15-20 minutes at a time, about 4 times a day, and also sleeping with the feet elevated. This uses gravity to help venous return.
Elevate for veins, keep dependent for arteries. Got it.
That's the core difference. Graduated compression stockings are also a cornerstone of management for mobile patients. They provide external pressure, tightest at the ankle, that helps squeeze blood back up towards the heart. Consistent use is key. Walking is still good because the calf muscle pump action helps push venous blood upward. But prolonged standing or sitting in one position should be avoided. Also avoid things that put pressure behind the knees, like crossing your legs tightly or sitting on the edge of a bed with legs dangling.
Makes sense. Promote flow upward, avoid pooling.
Precisely. And it's worth reiterating, as the source does, that many of the modifiable risk factors for atherosclerosis, which drives PAD, and factors that worsen CVI overlap with what we discussed for hypertension, things like smoking and nicotine use, poor diet, obesity, and a sedentary lifestyle. Addressing these underlying factors is key across the board for vascular health.
So controlling those helps with arteries, veins, and pressure.
Absolutely. And finally, the nursing notes for PVD in general really emphasize patient education, making sure you understand how to maintain perfusion in your limbs, the critical importance of meticulous skincare to prevent injury and breakdown, since healing can be impaired. Also, avoiding trauma to the area and really understanding the correct positioning for your specific condition dependent for PAD, elevated for CVI. For those who do develop ulcers, proper cleansing, possible debridement to remove dead tissue, and using the right dressings are vital parts of care.
Wow, that really was a deep dive into this source material. We journeyed from understanding how blood clots can form and potentially travel, explore the silent but powerful impact of high pressure in your arteries,
Yeah.
and look closely at how flow issues can manifest in very different ways in your legs and feet. It covers a lot of ground.
It really highlights just how interconnected your entire vascular system is, doesn't it? A disruption in blood flow, whether caused by sluggish movement, vessel damage, increased pressure, or a combination, can have significant ripple effects throughout your body.
Yeah, definitely. And understanding these concepts like the crucial factors in Virchow's triad, or the distinct differences in symptoms and management between intermittent claudication from PAD and, say, venous stasis ulcers from CDI gives you such valuable insight into how your body works and maybe what signs to watch for.
Exactly. It underscores that seemingly simple things like making conscious choices about your activity level, managing your diet, keeping stress in check, and addressing those big risk factors like smoking or diabetes. Well, they have real and profound impacts on maintaining healthy blood flow and your overall well-being.
So as we wrap up this deep dive based on the sources you provided, here's a thought to leave you with. Considering how common and often unseen these perfusion issues can be until they become pretty serious problems, how might simply building more daily awareness of your body's signals, maybe that calf ache when you walk, or swelling at the end of the day, or just paying a little more attention to activities like prolonged sitting or standing, how might that awareness serve as your most immediate and accessible tool for protecting this absolutely vital system of blood flow? Something to think about. Thanks for joining us on this deep dive.